the Fetal Heart Society with advanced modalities for assessing fetal arrhythmias. It's going to be a very, very good session. Please join us. And on the 21st, Dr. Mary Cohen is going to talk about imaging of ASD. We are happy to support on the 22nd and 23rd of May, the Baku Heart Days. It's the 7th Congress that Azerbaijani Society makes, and Congenital Heart Academy is very happy to support. And we are going to have one session about hypoplastic left heart syndrome, where Dr. Anderson, myself, Sasha, and Gil are going to talk about this very particular and interesting disease. And on the 27th, we have our fetal cardiology meeting. We are going to talk about several topics, so please join us. This is going to be very nice. And on June, we are already advising, because it needs some registration in advance, the Toronto Cardiac Symposium that is going to be about the Topology of Fallot. And we are very happy to support the host as well. This is for surgeons, so if you have a fellow or a young surgeon, or even an experienced surgeon who wants to try this interesting skill to do surgery on a 3D model. And please make your registration until the 15th of May. And this is going to be very nice. Sasha is going to be one of the speakers on the symposium, and he's going to be one of the faculty teaching how to do surgery for tetralogy of Fallot on this very, very nice 3D interactive post-conference. That's going to be a very nice. We participated last year, and this year is going to be tetralogy of Fallot. This is going to be a very nice. So if you're a surgeon and you're interested, please go to this website, 3dprintheart.ca, and make your registration. You're going to receive 2 3D models, printed models, and you are going to be able to do surgery during this this meeting, and then with the proctors helping you to go through all of the steps, including Sasha, who is going to be one of the proctors. And now with you, we have Dr. Anderson and Dr. Diane with this very nice talk, first part of transposition. Thank you, guys.
All, ladies and gentlemen, you will recall transposition and 2 sessions discussing which we agreed was the combination discordant connect across both the atrioventricular and the ventricular arterial junctions. Now you'll see by today that we're discussing another entity called transposition. Discuss this combination because, like congenitally corrected variant with a question, what is it? First known picture of the entity that we know transposition, singular anomaly. And this picture comes from 1796. And since then, as I've already intimated, it has been a contentious lesion. It has been defined of several features. And the question has related of these features should be paramount in the definition. On the basis of the ventricular origin of the arterial trunks, Or should we be looking at the relationship between those arterial trunks? Or, again, problem in the past is that those defining the entity have tried to put all of these together. Whereas in reality, the features take away the control over the passage stance unequivocally. The most important feature is the ventricular origin of the arterial trunks. And so we can make a straightforward definition of transposition. We find transposition when the aorta arises from the morphologically right ventricle, the pulmonary trunk from the morphologically left ventricle. In other words, because it's created so many problems, as we are going to discuss over the also recognize that you're all going to continue to talk about it is discordant ventricular arterial connections that are the essence of transposition being problems. And there now you see the major reason for all these problems, because for many years, rather than taking the ventricular origin of the arterial as the major definition, people diagnosed transposition whenever the aorta was located anteriorly relative to the trunk. They were describing the combination of double outlet, right ventricle, when the aorta was anteriorly located. And if you were defining transposition on the basis of the anterior aorta, there was nothing wrong in talking about double outlet right ventricle with transposition. But now, which we agreed was the combination of discordant connections across both the AD by day, but we're discussing another entity called transposition. And we're going to have 2 sessions to discuss this controversial, starting off, as you see, with a question: what is it? And you see a picture, the first known picture of the entity that we now call transposition. But when it was first described, it was my countryman, Matthew Bailey. Since then, as I've already intimated, it has been a contentious lesion. And that reflects the way, because it is the combination of several features. And the question, which of these features should be paramount in the definition? So the question is, should entity on the basis of the ventricular origin of the arterial trunks? Should we be looking at the relationship between should we be taking note of the morphology? And the problem in the past is those defining the entity have tried to put all of these together, whereas in reality, the features are mutually independent. And as we will see, if we separate out these features, we can take away the controversies. But, and from my stance, unequivocally, the most important feature is the ventricular origin of the arterial trunks. And so we can make a straightforward definition.
Hi guys, we are so sorry. We are trying to fix this problem on the transmission. We are going to try to start again to see if it gets better, okay? We are so sorry.
Well, good afternoon to you all, ladies and gentlemen. You will recall that last week we discussed congenitally corrected transposition. And we spent 2 sessions discussing this lesion, which we agreed was the combination of discordant connections across both the atrioventricular and the ventricular arterial junctions. Now you will see by the title of my opening image today that we're discussing another entity called transposition. And we're going to have 2 sessions to discuss this combination, because like the congenitally corrected variant, this lesion over the passage of time has also been controversial. So I'm starting off, as you see, with a question: what is it? And you see a picture, the first known picture of the entity that we now call transposition. But when it was first described, it was simply called a singular anomaly. And this picture comes from 1796. It's a picture made by my countryman, Matthew Bailey. And since then, as I've already intimated, it has been a contentious lesion. And that reflects the way it has been defined, because it is the combination of several features. And the question has related to which of these features should be paramount in the definition. So the question is, should we be defining the entity on the basis of the ventricular origin of the arterial trunks? Or should we be looking at the relationship between those arterial trunks? Or, again, should we be taking note of infundibular morphology? And the problem in the past is that those defining the entity have tried to put all of these together, whereas in reality, the features are mutually independent. And as we will see, if we separate out these features, we can take away the controversies. But over the passage of time, that was not the case. So we must now ask which of those features is most significant and which we should be using nowadays. And from my stance, unequivocally, the most important feature is the ventricular origin of the arterial trunks. And so we can make a straightforward definition of transposition. We find transposition when the aorta arises from the morphologically right ventricle, the pulmonary trunk from the morphologically left ventricle. In other words, the arterial trunks are arising from morphologically inappropriate ventricles. And nowadays, as they say in the United States, if I had my druthers, I would call this discordant ventricular arterial connections. I would banish the word transposition because it's created so many problems, as we are going to discuss over the passage of time. But I also recognize that you're all going to continue to talk about transposition. So today we need to explain why it is discordant ventricular arterial connections that are the essence of transposition. And so we must then ask the question, why have there been problems? And there now you see the major reason for all these problems, because for many years, rather than taking the ventricular origin of the arterial trunks as the major definition, people diagnosed transposition whenever the aorta was located anteriorly relative to the pulmonary trunk. And indeed, so many also argued that not only did the aorta have to be anterior to the pulmonary trunk, there also had to be discontinuity between the leaflets of the aortic and mitral valves. In other words, there needed to be a subaortic infundibulum or a subaortic conus. And then those who argued that whenever you had an anterior aorta, you could call it transposition, they would describe double outlet right ventricle with transposition. But what they meant was that they were describing the combination of double outlet right ventricle when the aorta was anteriorly located. And if you were defining transposition on the basis of the anterior aorta, there was nothing wrong in talking about double outlet right ventricle with transposition. But now, if we are to equate transposition with discordant ventricular arterial connections, it obviously makes no sense whatsoever to talk about double outlet right ventricle with transposition. So that's why we have to be precise with our definitions. The other problem of using the anterior aorta for the definition of transposition, however, was that if you came across hearts in which the aorta was posteriorly located but was still arising from the right ventricle, whereas the anteriorly located pulmonary trunk was arising from morphologically left ventricle, if you were using the definition, the anterior aorta, you could not call that transposition. And as we will discuss, that led to a very significant polemic. So let's look further into the problems of taking the anterior aorta as the definition of transposition. Because we also know that very rarely the aorta can still be arising from the morphologically left ventricle, in other words, have a concordant ventricular arterial connection, and yet be anteriorly located relative to the pulmonary trunk. So in the past, for those who were using the anterior location of the aorta as the definition of transposition, here we had an anterior aorta arising from the morphologically left ventricle and hence satisfying the definition of transposition. So that was called anatomically corrected transposition, distinguishing it from the lesion we were discussing last week, which of course was physiologically or congenitally corrected transposition. And here is such a case. At first sight, you may not appreciate that this indeed is the aorta arising from the morphologically left ventricle. But let me show you what's going on. Here we're looking at this heart from the stance of the morphologically right ventricle, and there's no question that the pulmonary trunk is arising from the morphologically left ventricle. The pulmonary trunk is supported by a completely muscular infundibulum. So there is the aorta, and you see that directly beneath the aorta, there is an interventricular communication. So we have to ask ourselves, what is the origin, the ventricular origin of this aorta? And you'll note here that there has been a cut made in the outlet septum. So if we put the outlet septum together, which I've done in this next picture, now you can see that the aorta is indeed arising anteriorly from the morphologically left ventricle. So this is the lesion that in the past was called anatomically corrected transposition. It is a morphologically left ventricle. Coming into it, we have mitral valve. There is where the two parts of the muscular outlet septum have now been glued together. And you see that the aorta is not only arising anteriorly from the left ventricle, there is also a complete muscular subaortic infundibulum. There it is. So we have the anterior aorta arising above a muscular infundibulum from the morphologically left ventricle. We have concordant ventriculo-arterial connections. So this is what in the past was called anatomically corrected transposition, in this instance with a muscular outlet ventricular septal defect. Now there are problems on several fronts with the use of this term, because for many years it was considered to be an embryologic impossibility. Well, now you know it's not an embryologic impossibility, because I've just shown you a case. And my good friend Richard van Praag, in fact, over the years also described several cases with this combination. But he did not like the term anatomically corrected transposition for all of the reasons we've discussed thus far. So he suggests we should rename this entity and we should call it anatomically corrected malposition. And here is where he grouped together all his arguments in favor of this term. Many of you will know that he always also uses malposition for describing the arterial relationships in the setting of double outlet right ventricle. I should tell you, I am not very fond of the term malposition, and I'll explain to you why that is the case. But if you look at this review, you'll see why Richard considered it better to rename this entity as anatomically corrected malposition. And here is one of the drawings he made to illustrate what is going on. And you see that Richard has shown that this setting at the ventricular arterial junctions can go along with various arrangements at the atrioventricular junctions. And there you see his segmental combinations. Now, in a way, it's also paradoxical. But the reason that Richard introduced the notion of segmental analysis was to avoid having to pigeonhole entities. And yet here, we have to pigeonhole these entities to know what is going on. Because to distinguish these various entities, we'd have to call them anatomically corrected malposition SDL, or anatomically corrected malposition SLD, or anatomically corrected malposition ILD, or the final one, anatomically corrected malposition IDL. Now it becomes increasingly difficult. You're going to have to concentrate very hard to understand where we're going from here. Because Richard also introduced these other somewhat arcane entities. And you see one is called isolated ventricular discordance. There's another one that's called isolated infundibular arterial discordance. And you'll remember 2 weeks ago, we discussed how in segmental nomenclature, the key was the harmony or disharmony between the segments. And in the arrangement you see there, infundibular arterial discordance, Richard is introducing the infundibulums as yet a further segment of the heart. You'll note there that there's also one of these in the setting with dashed lines around it, because at the time this combination had not been reported. But is it easy to understand all these various combinations? And is it then easy to distinguish between what Richard calls anatomically corrected malposition and what he would like to call isolated ventricular discordance? And I would suggest to you it's not. So let's take a little bit of time and let's dissect further the similarities and differences between these segmental arrangements, all of which relate to the location of the aorta. So here we have that combination, which we've discussed. Initially was called anatomically corrected transposition. Now it's been described as anatomically corrected malposition. And this is the arrangement which the atrial chambers are usually arranged. As you see there in the segmental combination, they are S. There is discordant atrioventricular connections because we have SL, segmental disharmony. But then, arising from the mirror-imaged ventricular mass, left-hand ventricular topology, we have concordant ventricular arterial connections, the aorta arising from the left ventricle, the pulmonary trunk from the right ventricle. But what I'd like to do is I'd like you to compare it with this variant, which in fact, if you look at what's going on, the right atrium is joining up to the left ventricle, which is giving rise to the aorta. The left atrium is joining up to the right ventricle, which is giving rise to the pulmonary trunk. Richard wants to call this isolated ventricular discordance. And look at the segmental notations, as in the one you see to your left hand, which we're going to call anatomically corrected malposition. In both of these combinations, we have cytosolitis, usual atrial arrangement. In both of them, we have discordant atrioventricular connections. But here is the hooker, because allegedly, in the combination you see to your right hand, there is an aorta that is directly adjacent to the mitral valve. So the only difference between these entities is that to your left hand, you see an infundibulum supporting the aorta. To your right hand, you see there is fibrous continuity between the leaflets of the mitral valve and the aortic valve. And that is what Richard is arguing permits us to call that cytosolitis at the ventricular arterial level. But is that really the case? Now, as I say, this is complicated, so you must bear with me while I share with you what happens when we have left-handed ventricular topology. And you'll remember, left-handed ventricular topology is part and parcel of the most frequent example of congenitally corrected transposition. And here, now you see the mirror-imaged normal heart. We have mirror-imaged atrial chambers. The mirror-imaged atrial chambers are connecting to the ventricles in the setting of left-handed ventricular topology. We have concordant ventricular arterial connections with spiraling arterial trunks. This is no more than the normal heart in mirror-imaged format. But let's go back now, and let's compare that to the heart that Richard wanted to call isolated ventricular discordance. Because let's look what's going on at the ventricular arterial level. And let's see what happens when we have left-hand ventricular topology supporting mirror-imaged normal ventricular pathways. And that's what you see to your left hand. But here, Richard has argued that this is cytosolitis of the arterial roots. But it's only cytosolitis when these arterial roots are supported by right-hand topologic ventricles. And here we do not have right-handed ventricles. we have left-handed ventricles, and in the setting of left-handed ventricles, when we have what is the typical arrangement, we have spiraling arterial trunks, as you now see to your left hand. So I don't think it's justified to describe the arrangement you see to your right hand as solitus at the level of the ventricular arterial junctions. And that is the problem I have with this attempt to pigeonhole these various lesions. Because what are the features that put them all together? And I can show you that in this heart. It's a picture of the heart from the Idris archive at Lurie Children's Hospital in Chicago. In fact, I showed you this heart before. We looked at it last week because it has discordant atrioventricular connections. So you're looking at the right-sided, morphologically left ventricle. And it is a morphologically left ventricle in the setting of left-handed ventricular topology. And if you will remember, last week I showed you that this morphologically left ventricle, which is right-sided, is giving rise to an anteriorly located aorta. We have concordant ventricular arterial connections. But here we have a small infundibulum with the infundibular musculature interposing between the leaflets of the aortic valve and the mitral valve. So in this setting, using the Van Praaghian nomenclature, I would be justified in calling this anatomically corrected malposition. But suppose instead of that little bit of myocardium you saw there, there would have been fibrous tissue unifying the leaflets of the aortic valve and the mitral valve. Then, if we were using Van Praaghian nomenclature, we would have to call this isolated ventricular discordance. And to me, that makes no sense at all. It does not make any sense to argue that 1 millimeter of infundibular musculature makes the difference between anatomically corrected malposition and isolated ventricular discordance, or as some of you might want to call it, isolated ventricular inversion. Apart from anything else, it breaks the morphological method, because you recall we should not be defining one variable, anatomically corrected malposition, isolated ventricular discordance, on the basis of another feature that is variable, the structures supporting the aortic root above the morphologically left ventricle. So it was initially called anatomically corrected transposition. Richard suggested we should describe it either as anatomically corrected malposition, or if there was aortic to mitral continuity, we should call it isolated ventricular discordance. I would suggest we take a much simpler approach and we define the entity for what it is, concordant ventricular arterial connections, but then we emphasize the major feature that distinguishes it from the usual concordant ventricular arterial connections, and that is the parallel nature of those arterial trunks. And it doesn't matter what is happening with the infundibular morphology. We simply describe the combination as concordant ventricular arterial connections with parallel arterial trunks. And this is what I did with my colleagues from the Hospital for Sick Children in Toronto. This is a review we published quite some time ago now. Tisca Caval-Garrido is now working in Montreal. Dr. Bernasconi went back to Switzerland. You see Don Perrin, who was the archivist of the Toronto archive. In fact, one of the hearts I've shown you today was from the archive and myself. And we're going to talk about this combination in 3 weeks' time, if we can get the hearts together. So we'll share with you the reasoning why we believe these combination of lesions are better considered as concordant ventricular arterial connections with parallel arterial trunks. So let's come back now and let's discuss the other problem that we had with using the anterior aorta as the definition of transposition. Because what happens if we have discordant ventricular arterial connections, but the aorta is posterior? And as I've already intimated, this combination created a significant argument in 1970, because once again, it was Richard who described this entity with a group of co-authors. And here you see his paper published in the American Journal of Cardiology. In fact, I've got 71 wrong, I think it was. I've got 1970 wrong, it was in 1971 rather than 1970. But this created a bit of a kerfuffle between my other good friend and colleague, Bob Van Meerop, because at the time, Bob was taking anterior aorta as the defining feature of transposition. So obviously, if that was his definition, if the aorta was posteriorly located, it couldn't be transposition. Richard responded to this editorial with one of his own, suggesting that, in fact, it did clarify the situation to define transposition on the basis of the ventricular arterial connections. And I think we've come to accept that fact. And this is the type of heart that sparked that major disagreement. So this is a heart from the Birmingham archive. And there you see the aorta. It is positioned posteriorly and to the right, but by the cut, you see it as arising from the right-sided ventricle. And I'm going to show you in just a moment that right-sided ventricle is the morphologically right ventricle. And there is the second cut, which is leading up to the pulmonary trunk. The arterial trunks are normally related, but they are discordantly connected. So here is the outflow tract of that right-sided morphologically right ventricle. There it is. It is supporting the aorta. And you see there is the left coronary artery arising from the aorta. There is an outlet ventricular septal defect. And that is also an interesting defect. It is opening between the limbs of the septomarginal trabeculation. It has a muscular posterior-inferior rim, but this is the other feature that was problematic for Dr. Van Meerop, because in the roof of the defect, there is fibrous continuity between the leaflets of the aortic and mitral valves. Another reason to disqualify it from transposition as far as Dr. Van Meerop was concerned. And here we see the morphologically left ventricle, which is giving rise to the pulmonary trunk. There's a large subpulmonary infundibulum. There is the ventricular septal defect. And in the roof of that ventricular septal defect, there was fibrous continuity between the leaflets of the aortic valve and the mitral valve. This is posterior transposition. And it tells us again, the blood was going the wrong way round because of the ventricular arterial connections. And that is why it is the ventricular origin of the arterial trunks, the aorta from the morphologically right ventricle, pulmonary trunk from the morphologically left ventricle, that is the most important feature. But we now need to take account of the fashion in which the atrial chambers are connected to the ventricles. Because what we're going to look at very shortly is that the combination we are discussing now is discordant ventricular arterial connections with concordant atrioventricular connections. Last week, we discussed the congenitally corrected variant, where the discordant connections of both the atrioventricular and the ventricular arterial junctions cancel each other out. We can have a combination of discordant ventricular arterial connections when the atrial appendages are isomeric, and then the atrioventricular connections are mixed. You all know that when you have double inlet left ventricle, most frequently you have discordant ventricular arterial connections. So here is transposition with double inlet ventricle. Or we can have transposition when we have absence of one atrioventricular connection, most frequently tricuspid atresia. The default option we are talking about for the finding of discordant ventricular arterial connections is when we have that with concordant atrioventricular connections. And that is what we are talking about for the next 2 weeks. And we are simply going to call that transposition, because we would be specific with our other combinations. So this is what we're now going to talk about. Here, the morphologically right atrium is where we expect it to be. It's connecting across a mitral valve with the morphologically right ventricle, and it's giving rise to the aorta. So the circulations are in parallel rather than in series. So the morphologically left atrium is connected to the morphologically left ventricle, but with this combination, the morphologically left ventricle is pumping the blood back to the lungs. And this is the essence of transposition. So here you see it with usual atrial arrangement. You will not be surprised, therefore, to know that exactly the same combination can be found when we have mirror imagery. So here, mirror imaged atrial arrangement, the morphologically right atrium is left-sided. And now, because we have concordant atrioventricular connections, the morphologically right ventricle is also left-sided. We have left-handed ventricular topology. And it gives rise to the aorta. The blood, again, going round in parallel fashion rather than in series. So the right-sided morphologically left ventricle is connecting to the right-sided morphologically left ventricle and then pumping the blood back into the lungs. The entirety of the heart is mirror imaged. So now, to put this into context, Diane will show you the typical examples, transposition, of the setting. First of all, usual atrial arrangement. She's going to show you a heart with intact ventricular septum. And then she's going to show you somewhat of a complicated heart, which has transposition in the setting of left-handed ventricular topology and mirror-imaged atrial arrangement, in this example with an atrioventricular septal defect and common atrioventricular junction.
This heart has simple transposition, and we're looking at it in anatomic position so that the diaphragm would be located along my probe. And if we look at the arterial trunks as they exit the ventricular mass, the aorta lies immediately anterior to the pulmonary trunk. The right-sided atrium is morphologically right, with the superior cable vein entering its roof and the inferior cable vein its floor. You can see its blunt triangular tip and the broad attachment to the venous component. When I open this atrium, we'll see the prominent terminal crest that runs along that broad venous junction and gives rise to the pectinate muscles. So there is our prominent muscle bundle, or the terminal crest, and our pectinate muscles are extending around the right atrioventricular junction, determining that this is a morphologically right atrium. There's our coronary sinus, and you can see the eustachian valve. The flap valve at the floor of the oval fossa is competent, but is probe patent. So the oval foramen is probe patent. Guarding the inlet to the right-sided ventricle is a tricuspid valve with its septal and papillary muscle attachments. The right-sided ventricle is morphologically right with its coarse apical trabeculations. So thus far, we have concordant atrioventricular connections. Looking at the outlet of this morphologically right ventricle, we can see that the septomarginal trabeculation is quite prominent. There's its cephalic arm and its caudal arm, giving rise to the medial papillary muscle. And the subarterial infundibulum is supporting the aortic valve. So we see the brachiocephalic arteries branching from the aortic arch and the coronary arteries arising from the aortic valvular sinuses. So there is the right coronary artery and there is the left coronary orifice. Looking at the left-sided atrium, the pulmonary veins drained into this atrium, and the appendage shows us its tubular nature with the scallops and crenellations along its edge, and as well the narrow attachment with the atrial vestibule. Inside of this atrium, we see a smooth atrial vestibule and the narrow attachment of the appendage with the pectinate muscles confined to the appendage. So this is a morphologically left atrium. Here at the left atrioventricular groove, you can see the coronary sinus, which embryologically is a left atrial structure. The mitral valve is guarding the inlet to this left-sided ventricle, which is morphologically left. There are fine crisscrossing apical trabeculations, and the septal surface becomes smooth as we extend towards the outlet. You'll also note that there are no attachments to the septum of this mitral valve. The mitral valve is in fibrous continuity with the arterial valve, and it is the pulmonary trunk, giving rise to the left and right pulmonary arteries, as well as to the arterial duct. The arterial duct is patent in this case, and here on the left we have concordant atrioventricular connections and discordant ventriculo-arterial connections. You'll also note that the interventricular septum is intact in this specimen. So we have simple transposition with usual atrial arrangement, concordant atrioventricular connections, and discordant ventriculo-arterial connections. I also need to point out that this right ventricle has right-hand ventricular topology, so only the palm of my right hand can be placed on the septal surface with my thumb in the inlet and my fingers in the outlet. We can already appreciate that the apex of this heart is pointing to the right. There is also transposition and mirror-imaged atrial arrangement. So if we use sequential segmental analysis, we'll be able to see how all of our cardiac segments are attached to one another or connected to one another. So if we look at this left-sided atrium, we will see the inferior cable vein joining its floor and the superior cable vein its roof. It is a morphologically right atrial appendage and atrium because we have the blunt triangular tip and the broad attachment with the venous component. Confirming its right morphology are the pectinate muscles that we see encircling the atrioventricular junction. The atrium has been windowed so that we have a limited view inside, but we can appreciate that there is a thin remnant of the atrial septum with a large so-called septum secundum atrial septal defect. And there is our common atrioventricular junction. So this is an unbalanced atrioventricular septal defect with, in this case, left dominance, and there you can see the hypoplastic right component. Looking at this left-sided ventricle, it is morphologically right, and there are the coarse apical trabeculations. Arising from this left-sided morphologically right ventricle is the aorta, and there we can see the brachiocephalic arteries branching in normal fashion from what is a right aortic arch. The right-sided atrium has the pulmonary veins draining to it, and the appendage shows us a tubular structure with scallops along its edge and a narrow junction to the atrial vestibule. The atrial vestibule in this case is entirely smooth, and this is a right-sided morphologically left atrium. As I mentioned, the left side of this common atrioventricular junction was hypoplastic, so there we can see the crest of the ventricular septum and the scooped out nature, and the hypoplastic nature of this morphologically left ventricle. And this left ventricle lies in the hip pocket of the heart. This morphologically right ventricle, which is our larger of the two ventricles, has left-hand ventricular topology. So here is our interventricular septum, and only the palm of my left hand can be placed on that septum with my thumb in the inlet and my fingers in the outlet. I mentioned earlier that this specimen had transposition, and arising from the roof of this hypoplastic left ventricle was the pulmonary trunk, and there was pulmonary atresia. You can see that the aorta is anterior and leftwards of this smaller pulmonary trunk, and that's consistent with the left-hand ventricular topology. So we have mirror-imaged atrial arrangement with concordant atrioventricular connections and discordant ventriculo-arterial connections.
So the thing that links together what we're going to talk of as transposition is the combination concordant atrioventricular connections with discordant ventricular arterial connections. But then you have to recognize that there are variable features. And one of those, you'll know about this already because we've discussed it, is the arterial relationships. And you will also appreciate that there can be variability in infundibular morphology. Now we need to talk a little more about arterial relationships, because I'm sure that the majority of you all around the world will be calling what I like to call transposition. You'll want to call it de-transposition. But is it suitable to call the combination of concordant atrioventricular with discordant ventricular arterial connections, can we call that justifiably de-transposition? Well, let's look at this heart. This is a picture taken in the operating room by my late friend and colleague, Benson Wilcox, who was the chief of cardiothoracic surgery at the University of North Carolina. It's a beautiful picture. This has right-handed ventricular topology. There is usual atrial arrangement. Right atrium is joining to the morphologically right ventricle. And there is the aorta arising from morphologically right ventricle. You see there, it's giving rise to the right coronary artery. There is the pulmonary trunk, which is posterior to the aorta and which is arising from the morphologically left ventricle. We have discordant ventricular arterial connections in combination with concordant atrioventricular connections. And we've agreed that it is that combination in the setting of usual atrial arrangement that gives us transposition. If we were using Van Praaghian terminology, we would call this transposition SDL. And there'd be no doubt that this is the lesion which I would simply like to call transposition. It is not, however, de-transposition. It is, of course, de-loop transposition. So many would argue that what we're doing here, we're using D to describe the loop rather than the position of the arteries. But is de-loop transposition a suitable synonym? Look at this heart. This heart is very similar to the one that Diane has already shown you with mirror-imaged atrial arrangement. There is the left-sided, morphologically right atrial appendage, the right-sided, morphologically left atrial appendage. We have mirror-imaged atrial arrangement. And the atrial chambers are connected to their morphologically appropriate ventricles. We have concordant atrioventricular connections. This is transposition with mirror-imaged atrial arrangement. And what is the relationship? The aorta, it is anterior and left-sided relative to the pulmonary trunk. So in Van Praaghian nomenclature, this is transposition ILL. So it's L transposition, but it's not congenitally corrected. It is transposition, but it's not detransposition, it's not D-loop transposition. And we have a further problem, because transposition IDD is detransposition, but is congenitally corrected transposition. So I think it's much easier just to describe transposition and to use the D's and the L's simply to describe the arterial relationships. And detransposition is not a suitable term for distinguishing between what I would like to call transposition in its regular and congenitally corrected variants. So what about infundibular morphology? Well, usually there is a subaortic infundibulum, and usually there's fibrous continuity between the leaflets of the pulmonary and mitral valves in the left ventricle. Rarely there can be bilateral infundibulums. Sometimes, as you've seen, there can be fibrous continuity between the leaflets of the aortic and mitral valves. So here is one of the hearts that has an infundibulum in the left ventricle. There is the large infundibulum. The presence of that infundibulum does not stop us describing this as transposition because it has concordant atrioventricular connections with discordant ventricular arterial connections. So next week, we're going to look at the variants of transposition. And amongst those, we will be discussing the associated malformations. And perhaps the most important of those is the ventricular septal defect. We'll also next week discuss the influence of obstruction of the left ventricular outflow tract. You know that oftentimes there is an atrial septal defect. If not, you will create one with balloon septostomy. There can be patency of the arterial duct, as you've already seen in the heart shown to you by Diane. But before we finish today, I'd just like to say a few words about the arrangement of the coronary arteries, because that is also going to be an important consideration when next week we look at, in more detail, the morphology of transposition. And here we must note that almost without exception, coronary arteries arise from the aortic sinuses that are adjacent to the pulmonary trunk. Now, we're going to be discussing next week the variations you can find in the way coronary arteries take their origin from those sinuses. So, to recognize the varied origin of those three main coronary arteries, the right coronary artery, circumflex artery, the anterior interventricular artery, we have to distinguish between the valvular sinuses. And this is the essence of what we call the Leiden Convention. This is what we're going to be talking about here. You're looking at the base of the ventricular mass from the heart that has transposition. There is the aorta. It happens to be anterior and right-sided in this particular heart. And there are the coronary arteries. As you can see, they are arising from the sinuses of the aortic root that are adjacent to the pulmonary trunk. So how are we going to distinguish between those sinuses? As I say, we do so using the Leiden Convention. Now, for better or worse, and last week, Dr. Silverman pointed out the problems that you have as echocardiographers because you look at the heart from the base, from the apex rather, looking towards the base. In order to use the Leiden Convention, we have to look down on the aortic root and we have to consider ourselves as a little surgeon. There you see the surgeon as a little mannequin, and we stand in the non-adjacent sinus of the aortic root and we look towards the pulmonary trunk. So you'll appreciate here I'm showing you the rearrangement in the normal heart. And now when we stand in this non-adjacent sinus and we look towards the pulmonary trunk, one of the sinuses will be to our right hand. And that is the sinus we call sinus number 1. And in the normal heart, sinus number 1 gives rise to the right coronary artery. It follows then that the other sinus to our left hand is number 2. And in the normal heart, that gives rise to the left coronary artery. So what happens in the most frequent example of transposition? So this is what you have to do. You have to stand in the non-adjacent sinus. Remember, you have to position yourself such that you are in the non-adjacent sinus. You are standing on the base of the ventricular mass. You are looking towards the pulmonary trunk. And then again, one of your sinuses will be to your right hand, and we're going to call that sinus number 1. And what we will find is that in the commonest example of transposition, sinus number 1 will give rise to the main stem of the left coronary artery, which will then branch into the circumflex and anterior interventricular arteries. And in the commonest example of transposition, the left-handed sinus number 2 will give rise to the right coronary artery. But the variation depends on the way these 3 main coronary arteries arise from one or other, usually both, of these left-handed and right-handed sinuses. So the reason we stand in the non-adjacent sinus, we look towards the pulmonary trunk, is simply to distinguish between those sinuses. And Diane now is going to show you how this works and how we can position ourselves in that non-adjacent sinus. We can look towards the pulmonary trunk and we can distinguish between our right-handed and left-handed sinuses.
This is a normal heart, and we're looking at its base so that we can see the aorta as it's related to the pulmonary trunk, and we can look at the valvar sinuses with relationship to the coronary arteries. So typically, the surgeon or the observer will stand in the non-adjacent sinus of the aorta, and I have this little USB port of a surgeon that I'll use for demonstration, so that the surgeon is in the non-adjacent sinus, so looking at the pulmonary valve. It is the farthest sinus from the pulmonary trunk, and you can see that the surgeon's right hand is to the right hand facing sinus, and the surgeon's left hand is to the left hand facing sinus. And some refer to the right hand facing sinus as sinus number 1 and the left hand facing sinus as sinus number 2. So in the normal heart, standing in the non-adjacent sinus, we see the right coronary artery arising from sinus number 1 or the right hand facing sinus, and the left coronary artery arising from sinus number 2 or the left hand facing sinus. We're looking at the short axis of a heart that has transposition with usual atrial arrangement, and you'll see that the aorta is almost directly anterior to the pulmonary trunk. And if we find the non-adjacent sinus, this is that sinus which is farthest away from the pulmonary trunk. So if we put our little surgeon in that non-adjacent sinus, you'll see that his right hand goes to sinus number 1, which is the right hand facing sinus, and gives rise to the left coronary artery. His left hand, in turn, is pointing to the left hand facing sinus, or sinus number 2, and it gives rise to the right coronary artery. So the way I always remembered this is that in transposition, my right hand will go to the sinus that gives rise to the left coronary artery, and my left hand gives rise or goes with the sinus that gives rise to the right coronary artery. So in essence, my hands are transposed for what coronary artery they would point to based on the right and left hand facing sinuses. And I will point out that in this particular specimen, you'll see that the infundibular branch is coming from the left main coronary artery, and the first branch from the right coronary artery is the artery to the sinus node. So that the key feature is to distinguish between the sinuses so that abnormal patterns can be recognized. This heart shows the usual variant, which exists in about 3/5 of cases with usual transposition. In unusual variants, it's necessary to distinguish between the sinuses, and then handedness always works, irrespective of how the arterial trunks are related to one another as they exit the ventricular mass. So the system is basically independent of spatial relationships. So it's always the case that one sinus will be to the right hand. So if I'm in this sinus farthest from the pulmonary trunk, one sinus will be to the right hand, which is sinus number 1, and in this case gives rise to the left coronary artery. And then one sinus will be to the left hand, or sinus number 2, which gives rise to the right coronary artery. And the only exception will be in hearts that have transposition with a bifoliate aortic valve.
So what I hope we've done now is set the scene for understanding what I would like simply to call transposition, because it is the default option of all the hearts that have discordant ventricular arterial connections. It is the combination that goes along with concordant atrioventricular connections. So whenever I have hearts now that have this combination, concordant atrioventricular connections, discordant ventricular arterial connections, I simply call it transposition. I'm aware that the majority of you will add of the great arteries, or TGA, but I know of no one these days who talks about transposition of the great veins, so I think it's simple. It's enough simply to call it transposition. Next week, we're going to show you that you need to put this into the context of the associated malformations, but today I've already shown you that we also need to take into account the relationships between the arterial trunks, the infundibular morphology. But the bottom line, transposition is no more, no less than the combination of concordant atrioventricular connections with discordant ventricular arterial connections. And I put it to you, if you approach it on that basis, it becomes a very simple lesion to understand, and the use of that definition dispels all the multiple controversies that have existed over previous years. So next week, we're going to put all of this into practice, and we're going to show you the variations we can find in the setting of transposition.
Amazing talk as usual, Dr. Anderson. I'm very interested to see what you're going to have next week. And thank you, Diane, for the amazing images. And I really like the surgeon as your USB. It was very, very nice and gave us a very good understanding of it. Thank you very much for that. So as usual, I'd like to ask Dr. Silverman to start with his considerations.
Thank you very much. Yes, great talk as usual. I think having grown up in the Andersonian school, I haven't had these problems that perhaps other people have for reconciling two different nomenclatures. And I think that what Bob has done for us today has tried to reconcile the differences between the various nomenclatures. And I think it's quite clear, but really quite difficult to understand. And as one of the participants has said, is there a CD that you can see to see this talk again? And the answer is, well, they are all recorded and are on the website. So I think you can appreciate that. So from my point of view, as an echocardiographer looking at this, I don't think that we're going to get into much trouble, because we have to follow the blood flow in a sequential fashion from the vena atrial area through to the great vessels. So once you use a descriptive terminology, you will get to understand these various different nomenclatures. The posterior transposition is not a problem for me. I've only ever seen one case from the Children's Hospital in Texas. And it is quite clear as you follow this in sequence that the left ventricle gives rise to the pulmonary trunk and the right ventricle gives rise to the aorta. in this condition. So it's clear that one cannot get into trouble with this echocardiographically. The only other problem that I have is with the little USB mannequin. Not that I have any problems with the mannequin die, but I have problems with the fact that you put the aorta down, as we look at it, posterior rather than rotating the heart 180 degrees so that it comes in the area that we can see that echocardiographically. And that's my only comment, is that I would have to turn that upside down to relate it better to an echocardiographic projection. Thank you.
Thank you, Dr. Silverman. Guys, please type your questions on the Q&A chat box, so then we can discuss with the panelists.
In fact, can I take one of the points that Norman made there? Because there, if you look at the question and answers already, you'll see that my good friend Jagannath has made a very significant point, that perhaps I confuse things by trying to explain the problems that have existed with, or at least my own problems with Van Praaghian terminology. But I recognize fully that there are still many people who are wedded to Van Praaghian terminology. But I think, to me, the problem is that people do not use Van Praaghian terminology in its pure form. Because if you use Van Praaghian terminology in its pure form, you would not be talking about D transposition or L transposition. You would have to say transposition SDD or transposition SDL, because always Richard puts the lesion first and then gives the segmental nomenclature. And so what I've tried to do today, and I take Jagannath's point, it is difficult to understand. It's a complicated area. But I think that what Jagannath also says is true, and what Norman has said is true. If we simply describe what is going on, we cut through those controversies. But we have to recognize that we have to understand what is going on. And that's why I've been trying to explain what I see as the potential problems and to give my answer. Many people may not agree with me, but then that's what we can discuss. But I think we do have to recognize it is not an easy topic. And I said that throughout at the beginning of my talk. Today's discussion is not easy to grasp at first sight. And the other point that Norman made, the recording is now available. So if you're having difficulty with it, you can go back and you can listen to it again, because I was listening to it and I think I did make the points that I was hoping to make, recognizing Jagannath's points that if we had a choice, we wouldn't have to make these distinctions because we'd still be describing things as we are today. But we don't do that. We have to recognize the evolution of what is happening. And I think we have to try and understand what is going on. So that's why I did it. Maybe it was inappropriate, but you can go back and you can look at it again. And I think, as I say, to me, the important point is to realize why we have had these differences.
I just want to make two little other points about looking at the video again. The first is that it clarifies a lot of the points when you go back, because you can ponder on the structures, rewind the tape, and listen again to the points saliently made by Bob Anderson. The other issue is that the pictures that Diane shows us are really quite magnificent, and I think we have to applaud them once again for their absolute clarity. And there were just 2 points that I saw that were very interesting. The first was in the simple transposition, the posterior bundle was easily identified in its position running on the septal surface of the left ventricle. And the other point that is beautiful is that there was malalignment between the cusps of the pulmonary trunk and the aortic trunk in the transposition, which not in this case, but in other cases, a pointer towards an intramural coronary artery. And so I think that just as I've looked at this again, when I would go back, I would see that these points are available and the specimens are definitely worth another study, and so beautifully demonstrated by Diane. Thank you.
We
Yeah,
have
Norman, I realized that the that specimen did have some, what some people call commissural mismatch, but I didn't describe it, and I will for next week because I know that that specimen does have that feature. So I'll make sure I mention it next week.
It's not a matter of, I realize that, you know, we are illustrating specimens for these points, but the specimens, just like the conference, are worth another look, and you'll see these features on it. And so I just wanted to point that out to the readers, that if they wanted to look at this mismatch, as you call it, or to find out where is the conducting tissue running when you see it on the left septal surface, the left bundle is very, very prominent. The posterior bundle is very easily identified.
The Jagannath Norman has made another very good point, that if you want to look at things the right way around, then turn the heart around when you're doing your echo, and then you can see it like the surgeons do.
Well, I think that's right, but it really does, you know, if you're doing a sweep, you can't suddenly turn the heart around like the surgeon sees it.
I know Diana's been trying to work out some way that she can get her little mannequin upside down, but as yet she hasn't worked anything out. Diana, have you cracked it for next week?
Well, I did do a video, but the surgeon will have to stand in the left ventricular outflow tract, facing with his back in the non-adjacent sinus facing the pulmonary trunk, and then the arms will swing backwards to match the right and left hand facing sinuses.
I'm not sure that makes it any easier to understand.
No, but I tried.
Your guts in a knot, I think.
I'll send it to you and you can tell me what you think.
Very good. We have two questions about the same thing, and it's a very interesting question. So when we have pulmonary atresia and the aorta arising from the right ventricle, should we call it TGA with pulmonary atresia?
It all depends on whether you can identify the ventricular origin of the pulmonary trunk. And in the case that Diane showed you, and I know she's going to show you that case again next week, so bear that in mind because it's a very complicated case. You noticed it had an atrioventricular septal defect in common junction, which is very unusual in the setting of transposition. But in that heart, she pointed out that she could trace the atrial pulmonary trunk back to the morphologically left ventricle. So if you can trace the atrial trunk back to the morphologically left ventricle, then you know that initially the arterial trunks were discordantly connected. The other question made a very good point, because the other questioner was saying, what if you do not have a pulmonary trunk? You just have confluent pulmonary arteries. Well, in that setting, essentially then you're dealing with a solitary arterial trunk. So there, I think you have to say the aorta is arising, or rather the solitary arterial trunk, which is functioning as the aorta, is arising from the morphologically left ventricle, and there's absence of the intrapericardial pulmonary arteries. I think in those rare cases, you have to be prepared to take your time and describe what's going on.
Okay, perfect.
I noticed we've had another question from Paolo Zielinski, and I'm afraid Paolo's lost me this time because I don't understand what he's asking about when he says straddling tricuspid valve. He says transposition is the combination of concordant atrioventricular and discordant ventricular arterial connections. And I see the point he's making. He's saying that if you have double inlet left ventricle, and the point I would make there, I would then say if you have double inlet left ventricle and you decide it is double inlet left ventricle, I would prefer to say double inlet left ventricle with discordant ventricular arterial connections, because if I had my own way, I would restrict the simple term transposition to the combination, the regular situation with concordant atrioventricular, discordant ventricular arterial connections. And I know you're all going to go on calling discordant ventricular arterial connections transposition, so I have no problem in calling that double inlet left ventricle with transposition. But for me as a purist, I would then say that is different from the specific, my default option, which would be concordant atrioventricular, discordant ventricular arterial connections.
Rodney frankly made a point on the chat box that is interesting. He's saying that maybe we should not call it only transposition and indeed transposition of great arteries, because we are not dealing only with the heart. So if you're going to codify the disease, for example, on your chart or using the International Disease Classification, so there's several transpositions of ovaries, of nerves, of other organs and other structures in the body. So maybe we should always say that it's transposition of the great arteries to be able, at least for documentation.
Well, is Rodney correct there? I mean, transposition, I think there are better terms. I mean, we're trying to purify the nomenclature. So we've done that for, and as Rodney knows, Rodney sits on the International Classification of Disease Committee, so he has to fight all these corners. But he's fully aware of the fact that none of the other people who use these terms have been through it with the detail that we have for cardiology. So, I mean, to me, transposition of the ovaries is a no-no term. And I simply would not use the same way that people in the past, people called mirror imagery. They called that transposition of the organs, but that's not transposition at all. Transposition is placed across. And it's perfect in the setting of the heart, because the arterial trunks, as Richard van Praag has said, are placed across the ventricular septum so they arise morphologically inappropriate ventricles. And I do not believe that anybody who is a cardiologist is going to think that if we say transposition, we're talking about transposition of the ovaries. So in this instance, Rodney, I'm sorry, but let's be realistic. We're trying to sort things out for cardiologists. Whatever the ovarians do, that's up to them. But if they want to call it transposition, then so be it. But I don't think that's going to bother any cardiologist.
Okay, is another point of view. This is true. And we have one question that's not really in the scope of this talk, but we have some time to discuss if Dr. Norman can do this. There's one question about how on the echo we can look of the subaortic infundibulum, if there's any tips that you can give him.
Well, the only thing is there's this little issue of continuity between the semilunar valve and the atrioventricular valve. And that's a difficult problem because echo as yet is not capable of defining fibrous as opposed to muscular tissue. And so there are always going to be problems with the entity when it's difficult. If there's a large distance between the two, that's easy to see. But when it's close by, it becomes very difficult on the basis of echocardiography to distinguish between fibrous tissue, which would be continuity, and muscular tissue, which would be discontinuity, as Bob showed so beautifully in that anatomically corrected malposition case that he had a specimen of. And he discarded the fact that there was that, because that is not the primary reason for distinguishing the chamber. And so I think that it's a moot point, but the difficulty always on echo is to look at that distance and see how big it is. And when it's small, it becomes extremely difficult to make that differentiation.
Okay, we have one last question from Richard Onalo. If we can say something else about the nomenclature of DTJ, LTJ, SDL.
Well, I think the answer there is we shouldn't be using it.
I was sure you were going to say that. I was 100% sure. I should have bet some money.
Well, Bob, I think that the point that you made that's most important about this is that Dr. Van Praag did a great job on looking at this, and he was very specific about saying things. So he would, and you've made this point before, is that you can't simply call something D-transposition or L-transposition, because that's actually not being true to how Dr. Van Praag talked about it. He talked about it as transposition SDL or transposition IDD. And so, you know, there is some, a lot of great sense in what Dr. Van Praag said. But I think that people have taken this out of his context most of the time. And I see this with my colleagues day in and day out. They talk about D-transposition and they talk about L-transposition. And in our little app that we described, we have patients, as with the same patient that you showed, that has a D-loop transposition, but the aorta is anterior to the left side. So, I mean, that's not L-transposition. It's just an L position, D-transposition. So the third segment in Van Praag is violated a lot of times in this issue.
What you say there is 100% true, and it's what we come down to, that the purity of the system. And in a way, that's the point that Jagannath's making, that if you describe what's going on, you are producing a pure system. But the other point, as you say, people all around the world are using these other systems. And that was what David Eason was trying to do when he created his atlas, because he wanted people to be able to speak both languages. And that's what I was trying to do today, to try to give you that link between the two. Because in 3 weeks' time, if all goes according to plan, I made the point we're going to try and collect together these hearts that have concordant ventricular arterial connections with parallel trunks. Now, last week, Norman, you will remember that you asked us if we would clarify this. You said, I think, if I recall, you said you'd only ever seen one case of concordant ventricular arterial connections with parallel trunks. And it's a fascinating group of hearts. So in 3 weeks' time, what we're going to try to do, we're going to try to collect the hearts together. Diane sadly doesn't have any, but Adrian has some. And we know that there is the heart that is available in the Idris archive at Lurie Children's, and Rohit Lumber has agreed that he will take a video of that heart. So what I'm going to try to do in 3 weeks' time or 4 weeks' time, we will discuss this specific issue and we'll clarify the issue of what many would call anatomically corrected malposition, others would call isolated ventricular discordance, what I would like to call concordant ventricular arterial connections with parallel arterial trunks.
Very good. It was an amazing session as usual, guys. Really, thank you. I'm sure everybody learned a lot, and we are looking forward for the next weeks, how we're going to continue this series. Thank you very much. See everybody on Monday for Dr. Silverman's sessions, guy.
Hi, and if he's doing double outlet right ventricle, I hope he's going to say all the right things.
You should join us as a panelist, Dr. Anderson.
You've already proved it, Bob. It's all proved and accepted by you. You are a co-author of this section.
Thank you very much, guys. Thank you very much for attending today. Please share this video with your colleagues. I'm sure everybody's going to learn a lot. Thank you very much. Bye-bye.
Bye, Grace. Goodbye, Sasha. Goodbye, Bob.